primary angle closure glaucoma, the pathology and the treatment options, what we have, how do we treat the acute stages of angle closure glaucoma, and what is the treatment of choice, what is the drug of choice. Okay, so that was clear to you, I hope. Next topic we will take on in glaucoma is, what is left is congenital glaucoma. Also, congenital glaucoma is very important for your exam point of view. Can you appreciate this image of the child? Can you see the image, this one? Can you see any anomaly in the cornea? Any anomaly is there? What can you appreciate? See, this word we have already discussed, ophthalmos, when we were discussing anatomy. So we have discussed the normal corneal diameter, right? So in that, yeah, bluish eye is there. And whatever the, what about the size of the cornea? The size of the cornea is also large. It is more than 13 millimeter, associated with raised intraocular pressure. Eyeball appears large in size. That is why it is called as ophthalmos. Buff means, I told you, it is bull's eye, right? So corneal diameter is more than 13 millimeters and it is associated with raised intraocular pressure. So there are certain signs and symptoms by which you can diagnose the ophthalmos. Okay, many of the patients, because the newborn child cannot tell his problem, right? So many of the cases get undiagnosed. Okay, because patient usually complains of, the parents complain of watering of the eyes, so which is a very common symptom in ophthalmos. So write down next topic which we'll discuss now. Ophthalmos. So write down ophthalmos, also called as congenital glaucoma. Congenital glaucoma, right? So obviously when there is glaucoma, some pathology must be there in the trabecular meshwork, right? Some pathology must be there in the trabecular meshwork, which is blocking the flow of aqueous humor, right? So what is the pathology in the newborn child? Write down the pathogenesis of congenital glaucoma. Pathogenesis of congenital glaucoma. It starts with trabeculodysgenesis. Trabeculodysgenesis means it is malformation of the trabecular meshwork. It is present since birth. Now, what is important for your exam point of view is the sign and symptoms of ophthalmos. So, in order to remember the symptoms of ophthalmos, a very easy mnemonic is there. You have, all of you have heard of BPL card, below poverty line. Card in symptoms of congenital glaucoma, where B stands for blepharospasm. Blepharospasm. The child is not able to open his eyes, right? Then photophobia. Yeah. And L stands for lacrime of eyes. Now, in question, if they ask you which is the most common symptom of congenital glaucoma, then answer will be lacrimation. Answer will be lacrimation. And if they ask you which is the earliest symptom, then answer will be photophobia. This is the earliest symptom. So very, very important. You have to remember BPL card. Then coming to signs, see this picture. GA under the microscope, can you see straight horizontal lines are there in the cornea? So these straight lines are called as Habs striae. They are called as Habs striae. They are typoma. Okay. So can you tell me, we have already discussed one type of striae we have already discussed. Can you tell me where we have studied previously striaes? In which topic was there? It was in Vox striae, right? So where it is seen Vox striae? Keratoconus, right? Keratoconus, good. So there are two striaes, Vox striae and Habs striae. Habs striae are seen in congenital glaucoma. So don't get confused. Habs striae are seen in congenital glaucoma. Okay. So Habs striae, remember, Habs striae are horizontal lines, whereas Vox striae, they are the vertical lines. So V for vertical and H for horizontal. Okay. V for vertical and H for horizontal lines. So write down. What are the important signs in congenital glaucoma? If they ask you which is the earliest sign in congenital glaucoma, answer will be hazy cornea. The newborn child will have hazy cornea. Second important sign is Habs striae. Habs striae. These are seen because of breaks in Descemet's membrane. D. They are horizontal. Usually they are. Third change, try to understand the concept behind the third sign which you will see in a newborn ophthalmos. See, by birth, the intraocular pressure inside the eyeball is very high. Okay, so what will happen? The newborn sclera has tendency to stretch. It is very elastic. Now, because the intraocular pressure inside the eyeball is high, what will happen? The eyeball will tend to stretch. Okay, so when the eyeball tend to stretch, what will happen to the axial length of the eyeball? The axial length of the eyeball will increase or decrease. Tell me in the chat box, if the intraocular pressure is high, newborn child has sclera has tendency to stretch. So what will happen to axial length? It will increase. Now you will tell me, if the axial length of the eyeball increases, the patient becomes myopic or hypermetropic? If axial length is more than normal, the patient becomes myopic. Right. Now you will tell me second thing, if your sclera, newborn child sclera is getting stretched, so obviously there will be thinning of the sclera, right? Now which structure is present beneath the sclera? Which is the second middle coat of the eyeball? Which layer is present beneath the sclera? If there is excessive stretching of sclera, sclera will be thinned out, right? So now you will tell me which layer of eyeball is present beneath the sclera. Choroid, right? Choroid is the middle coat, right? So choroid is present beneath the sclera. Okay, now write down the signs. Third sign, important sign is, because of continuous increase in intraocular pressure, it causes ophthalmos. It causes ophthalmos, due to which it will give you certain findings. Cornea will be enlarged and it is more than 13 millimeters in diameter. Your sclera will stretch. Sclera will stretch. There is stretching of sclera. That is why your sclera becomes thinned out. It is thinning, or there is thinning of sclera. Now this thinning of the sclera, because choroid is lying beneath the sclera, you will see a color of choroid also through this whitish sclera, and the baby will get bluish hue. So that is why you see blue sclera in ophthalmos. Now, because the patient becomes myopic because axial length is increasing in size, deep anterior chamber will become deep because myopes have deep anterior chamber. Myopes have deep anterior chamber. Clear? Next important sign, you can also see optic disc cupping. Due to increased intraocular pressure, it will affect on the optic nerve head, and the size of the cup disc ratio will increase more than 0.5. So optic disc cupping is also seen. Now coming to treatment of congenital glaucoma, right? So which is the earliest sign? Earliest sign, if they ask you, then the earliest sign is hazy cornea. Earliest sign is hazy cornea. So by the time patient presents to you in the OPD, most of the cases, the child has already developed hazy cornea. You cannot see behind the cornea. Okay. The rest of the anterior segments are very hazy. Okay. So in those cases, because most of the patients, when they present, they have already developed hazy cornea. So treatment of choice, write down. If they ask you treatment of choice in congenital glaucoma, it is called as trabeculectomy. You have to do surgery, trabeculectomy plus trabeculotomy. Trabeculectomy plus trabeculotomy. You just need to remember the names of the surgery here. No need to go into detail. Second treatment of choice is you can also go for only trabeculectomy. Only trabeculectomy. Third is goniotomy. Goniotomy. So if they ask you which is the first treatment of choice, if the child has clear cornea, the first treatment of choice is goniotomy. If the clear cornea is there in child, then treatment of choice is goniotomy. But in 90% of the cases, when the child presents to you in OPD, patient has already developed hazy cornea. So in that case, your treatment of choice becomes trabeculectomy plus trabeculotomy. Okay. So this is also important. This is also important. Any doubt in this congenital glaucoma? BPL card is clear? BPL card, blepharospasm. Okay. Now try to understand another important concept of visual field defects. Another important concept is there of visual field defects. So we have discussed about visual fields, the normal visual fields, right? Now, by which technique or by which method you will measure, you will check whether the patient is having visual field defects or not. So this is a machine with the help of which we can check whether the patient is having any visual field defects or not. So someone has doubt about blue sclera. See, our normal sclera is in newborn child, it is whitish in color, right? But because there is continuous stretching is there, so because of stretching, sclera becomes thin, right? Excessive thinning of the sclera is there. Now, when the one structure is very thinned out, obviously you will be able to see beneath the sclera, choroid is present. So you can see a bit of choroidish hue against the whitish sclera. So it will give you a bluish hue. That is why the sclera becomes blue in color in congenital glaucoma. Okay. Clear? Yes. So how you will check the patient is having visual field defects or not? Yesterday I discussed about the visual fields. Normal visual field I discussed when the patient is looking in straight without moving his eyes in primary gaze position, whatever area he can visualize, that is your normal visual field. Okay. Treatment of choice. Treatment of choice, if they ask you in exam that what is the treatment of choice if the patient has come to you in OPD and the hazy cornea is there, then treatment of choice becomes trabeculectomy plus trabeculotomy. But if they specifically mention that the patient cornea is clear, what is the treatment of choice? Then answer will be goniotomy. Answer will be goniotomy. Okay. So most of the time, the treatment of choice which we do is trabeculectomy plus trabeculotomy, because mostly the cornea has become hazy when the patient presents to you. Okay. Clear? Shall we move? Okay. So this is the machine which machine is used to check whether the patient is having any visual field defects or not, right? So if suppose I am normal individual, I don't have any signs of glaucoma, I do not have any visual field defects, and I am seeing straight in the primary gaze position. So this is my normal visual field, right? And somewhere my optic nerve will be there, which is acting as a blind spot, as we have already discussed, because of this optic nerve do not have any photoreceptor. So that area is my normal blind spot. Okay. And rest of the area I can appreciate in all the quadrants, 12 o'clock, 1 o'clock, 2 o'clock. Okay. Now suppose if I am a glaucoma patient, I am having primary opening and glaucoma. Okay. My cup dust ratio is 0.6. My intraocular pressure is 26 millimeters of mercury. Now I want to check whether I am having any visual field defect or not, to exclude any my third criteria. We have 3 criteria to diagnose glaucoma, right? So I will advise the patient one investigation which is called as perimetry, Okay. With the help of this method or with this investigation, we can check the visual field defects. So perimetry is used to detect any visual field defects. Okay. So there are very several types of perimeters in the market, and the most commonly used perimeter machine is this one. The name of this machine is called as HFA. We call in short form HFA is Humphreys Visual Field Analyzer. Humphreys Visual Field Analyzer. So you have to remember the name of this perimetry. It is used to detect visual field defects, and the name is HFA, Humphreys Field Analyzer. This much is clear or not? So you have to check whether the patient is having any visual field defects or not, and by which technique you check. It is called as perimetry. This is how the machine looks like. Clear or not? Give me a thumbs up if it is clear. No more Snell's. No, Snellen chart is used for visual acuity examination and not for visual field defect. We are talking about visual field, not vision. Okay. So suppose now I am presenting you in another scenario. Suppose I am glaucomatous patient. Okay. IOP is rise. IOP is suppose 26 millimeters of mercury and CD ratio is 0.6, 0.7. Now this is the machine. Here at this point, the patient keeps his chin. Okay. And here is the observer or the doctor standing. Now he will press some buttons over here, and some few light intensities are fired to the patient at this side. At this side, certain different intensities light, different intensity of light is fired in all the quadrants of his normal visual field. Okay, and the patient is asked to press a button whenever he sees a light in each and every quadrant. This much is clear or not? Yes or no? Give me a thumbs up if this is clear. What is the method? How we do? Patient keeps his chin. Doctor stands here. He presses some button and he fires some lights of different intensities in all the quadrants of his normal visual field. And patient presents a button in each and every quadrant whenever he sees the light. Okay. Now, a printout is after the investigation is over, the printout is come. Then what happens on the printout? You will see whether the patient is having any visual field defect in certain quadrant or not. Suppose the patient is not able to see in the 3 o'clock position. In that area, there will be a black chart will be there. Black area will be there in the normal visual field. Okay. So that area is called as your scotoma. That area is called as scotoma. So what is scotoma? Scotoma is a non-seeing area. Scotoma is a non-seeing area surrounded by seeing area. What does it mean? Suppose I am having scotoma at 3 o'clock. I am looking here at primary gaze position. So there is a certain spot which I am not able to appreciate. But around that spot, all of the area I can appreciate, I can see. Okay. So that black spot is called as scotoma. That black spot which I cannot see, that spot is called as scotoma. Okay, this much is clear or not? I'll get a printout of this investigation, and on the paper I will see in which quadrant the patient is not able to see, or the patient is appreciating certain scotomas or not. This much is clear? Give me a thumbs up. Okay. Okay. So write down visual field defects. Write down the visual field defects. So yesterday we have already discussed the normal visual field, and that was like this. So you will get a chart paper like this, right? So this was our blind spot. Normally, this is our normal blind spot. Superior quadrant, temporal quadrant, nasal quadrant, and inferior quadrant, right? So you will get a chart paper on which you will see certain scotomas. So what is the progression of the normal scotoma in glaucoma? How the scotoma progresses? As the glaucoma progresses, the size of the scotoma also increases. Okay. As the glaucoma progresses when we age, in a normal visual field, he can't be able to see. That is scotoma. So normally, the patient can see all of the area, right? Except the blind spot. But in glaucoma, there are scotomas. Yes. So in scotoma, he cannot see. In that particular area, he cannot see, and surrounding the scotoma, he can see. Do we use perimeter in only ophthalmos? In all type of glaucomas? Yes, we use in all type of glaucomas, not in ophthalmos, because newborn child will not be able to do this investigation. So this is only for adults. This is for POAG patients and angle closure patients. Okay. So this is done in all the types of glaucoma, not in ophthalmos. Patient needs cooperation in this investigation. So newborn child will not be able to cooperate. He will not press the button. Okay. Understood? So scotoma is a non-seeing area which is surrounded by your seeing area. You cannot see that scotoma. Clear? Now, as the glaucoma progresses, suppose I am 40 years of age and I have developed glaucoma. and my pressures are raised and my CD ratio is 0.6. But when I undergo this perimetry, suppose there are no visual fields, okay, no visual field defects are there at the age of 40. I was started on medication, but I was not very compliant with the medication. After 1 or 2 years, suppose I come back again with some vision loss and I undergo perimetry again, then I can see that there are certain scotomas in certain areas which I cannot see. So as the glaucoma advances, the size of the scotomas also increases. Okay, the size of the scotoma also increases as the glaucoma advances. Okay, so this much is clear. Give me a thumbs up if it is clear. Should I repeat? Now, if I am glaucomatous and I have developed a scotoma, suppose in this direction, I can see every other quadrant superiorly, temporally, there is no defect, everything is fine. But suppose in this direction, a small spot, a small scotoma is there, which I cannot see. Okay. So a printout comes after perimetry and the doctor can appreciate that, yes, there are certain scotomas and visual field defects are there. He started the patient on medication. Patient is not under control of the glaucoma. After 4 or 5 years, this small spot, suppose it progresses in size. It increases in size. Suppose initially this was this much of scotoma. Later on, after 5 years, it progresses and it is encroaching upon my superior area also. So this scotoma is encroaching other sectors also if my glaucoma is advancing. Okay, so do you get the point? The scotomas progresses as the glaucoma advances. Clear? So the glaucoma patients are advised to undergo perimetry every year. Every year they are advised to undergo perimetry so that doctor can appreciate whether the visual field defects are increasing or they are constant. Clear? Okay, so now write down the progression, how the scotomas progress. Okay, now write down, this is the first scotoma which is seen. This scotoma is called as paracentral. The name of this scotoma, suppose this is a small spot, small scotoma, which the patient is not able to appreciate. This scotoma, the name is called as paracentral scotoma. Now, if this scotoma further progresses, and join the horizontal line like this, in the second stage, this scotoma, if it joins a horizontal line, then this scotoma is called as Siedel's scotoma. Siedel's scotoma. Siedel's means sickle shape. This is sickle shaped scotoma. Okay. Now this, in the next stage, if it further advances and this scotoma joins the horizontal line in this direction also, like this, then this scotoma, the name is called as, then the third scotoma, the name is called as arcuate scotoma, also called as Jerem's scotoma. Jerem's scotoma. Okay. So if it joins the horizontal line, then this is called as Jerem's scotoma or arcuate scotoma. Now further the glaucoma advances, the further the visual field advances. Now if this line joins in lower half also, it progresses in lower half also, like this. if it joins like this, it progresses like this. Now this is giving you a shape of a ring, right? A ring is formed if it progresses. So that is why after germ scotoma, what comes? It is called as ring scotoma, also called as double arcuate scotoma. Double arcuate scotoma. There is unequal loss. Can you appreciate? I have not touched this point. So if there is unequal contraction in superior quadrant and the inferior quadrant, the lines have not joined, then this gap is called as, after ring scotoma, write down, this is called as nasal step. Nasal step scotoma. This is called as nasal step scotoma. Okay. So these names you have to remember how the scotomas progresses. How the scotomas progresses when the glaucoma advances. So this sequence you have to remember. It starts with paracentral scotoma. If this paracentral scotoma joins your horizontal line, it is called as cedar scotoma because it looks like sickle shape. And after sickle shape comes your arcade scotoma. And if the visual field defects comes in lower half also, nasal is which attach sedal and ring. Nasal is if there is unequal contraction in the superior and the lower half. If it is complete contraction, right? If they are joining, then it is ring scotoma. If suppose there is unequal contraction in superior and lower half, there is some gap is left, then it is called as nasal step. Then it is called as nasal step. So sedals, after sedals comes your arcuate scotoma. After arcuate comes your ring scotoma. Okay. Clear? So next we will be discussing about uveitis. So can you tell me what is the size of the pupil in iridocyclitis? Can you tell me what is the size of pupil in iridocyclitis? It is dilated or is it constricted? Is it dilated? The pupil is dilated or constricted? So we have discussed the differential diagnosis also. What is uveitis? The other name of uveitis is iridocyclitis. So we have already discussed in anatomy how many parts of uvea are there. How many parts of uvea? Most anterior part is iris. Iris is attached to ciliary body, right? And after ciliary body comes your choroid. So most anterior is iris, then in middle is ciliary body, and then comes your choroid. So if there is inflammation, if there is any inflammation in each part of this uvea, iris, ciliary body or choroid, then it is called as uveitis. Okay. So inflammation may involve all the three structures as a whole also, or individual structures, be it iris or ciliary body, they can also get inflamed. Okay. So based on the structure which is getting inflamed, we have to classify uveitis into anterior uveitis, intermediate uveitis, and posterior uveitis. So write down the classification of uveitis. Classification of uveitis. Classification of uveitis. Uveitis, it is inflammation of a part of uvea a part or whole of the uveal tract. Whole of the uveal tract. Now, first we will discuss anterior uveitis. First we will discuss anterior uveitis. Now, as we know in the anatomy, uvea has iris. It is divided into iris. It is divided into ciliary body and your choroid. Now, this ciliary body has two parts. Ciliary body has two parts. First part is called as pars plicata. Pars plicata, this is anterior part, okay? So anterior is the pars plicata and posterior part of ciliary body is called as pars plana. Posterior part of the ciliary body is called as pars plana, okay? Now coming to classification. First is anterior uveitis. So as the name suggests, anterior means anterior structure is getting involved. So which is the anterior structure? Right now there is inflammation of iris because iris is anterior, plus out of ciliary body, out in ciliary body, which is the anterior most part, pars plicata or plana. Plicata is anterior. So there will be inflammation of iris plus there is inflammation of pars plicata. There is inflammation of pars plicata. This anterior uveitis is also known as iridocyclitis. Itis means inflammation, cycle means ciliary body, and irido means iris. Okay. This is clear. So based on the structure involved, we will classify uveitis into several types. Okay. Okay. So we have discussed anterior uveitis. Second, write down intermediate uveitis. Intermediate uveitis. Intermediate uveitis, write down. It is inflammation of pars plana. It is inflammation of pars plana plus peripheral retina. And which liquid is present in retina? Vitreous humor. Now, can you tell me if the patient is having anterior uveitis, inflammation is there in anterior structures like iris and pars plicata, what will be the site of inflammation in anterior uveitis? Anterior segment, anterior chamber, or vitreous humor? No, posterior uveitis is not called as iridocyclitis. Iridocyclitis is only anterior uveitis. AC, right. So in anterior uveitis, the signs of inflammation are seen in anterior chamber. Okay. Whereas in posterior uveitis, the signs of inflammation will be seen in vitreous humor. Okay. So in intermediate uveitis, you will see inflammation of pars plana, peripheral retina, and obviously vitreous humor. Okay. So primary site of inflammation in intermediate uveitis is vitreous humor. It is vitreous humor. Now coming to posterior uveitis. Posterior uveitis is also known as retinochoroiditis. Retinochoroiditis. So as the name itself says, there is inflammation of retina as well as choroid. Both are inflamed, and the site of inflammation the signs you will see in both retina as well as choroid. Okay. So inflammation signs will be seen in retina as well as in choroid. Now, fourth is called as pan-uveitis. Right? Total means all the layers are getting involved. This means that there is inflammation of iris, choroid. All of the structures are getting involved in inflammation in pan-uveitis. In intermediate uveitis, there is inflammation of pars plana, peripheral retina, and vitreous humor. Okay, so in only anterior uveitis, you will see signs of inflammation in anterior chamber, and rest, intermediate, posterior, right? You will see signs of inflammation in retina and choroid. Okay, now one by one we will discuss each uveitis. First, we will take on anterior uveitis. Anterior uveitis, also known as iridocyclitis. This type of uveitis is most common form. This is most common form of uveitis. So in OPD setup, we are seeing maximum number of patients of anterior uveitis as compared to intermediate or posterior uveitis. Okay, this is the most common form. Now it is of two types. Anterior uveitis is of two types. Number one is granulomatous anterior uveitis. Second is non-granulomatous and non-granulomatous. So these are the two types of anterior uveitis which you have to remember. Iridocyclitis is anterior uveitis. What is iridocyclitis? Irido means iris. Cyclitis, cycle means ciliary body. So inflammation of iris and ciliary body is called as iridocyclitis. It is also called as anterior uveitis. Other name of iridocyclitis is anterior uveitis. So anterior uveitis is of two types, granulomatous uveitis and non-granulomatous uveitis. Okay, so there are certain diseases which you have to remember what are the causes of granulomatous and non-granulomatous uveitis. So write down causes. First is granulomatous. Causes of granulomatous anterior uveitis is tuberculosis, TB, tuberculosis. Second cause is sarcoidosis, tuberculosis and sarcoidosis. Okay. Now second is non-granulomatous anterior uveitis. Non-granulomatous anterior uveitis. Write down the causes. Write down HLA B27 associated diseases. HLA B27 associated diseases. Can you tell me which is the most commonly associated disease of HLA B27? In the chat box, can you tell me HLA B27 associated disease? Yes, right. Spondylitis. The full name is ankylosing spondylitis. Important one. Ankylosing spondylitis. Write down. It is ankylosing spondylitis. Second cause, write down, very, very important. This is also important, but this one is very, very important. Second cause is called as Behçet's disease. Behçet's disease. You have to remember the HLA also associated with Behçet's disease is HLA B51 or HLA B5. HLA B51 or HLA B5. Very important. This is important. Okay. So in Behçet's disease, remember, you will see mobile hypopyon. Cold mobile hypopyon. Okay. Cold mobile hypopyon is seen. Now, can you tell me what is hypopyon? We have already discussed in ulcers. Hypopyon was, what is hypopyon? What is hypopyon? Pyon means pus in AC, right? So why it is called as cold mobile hypopyon? Is it chilled? No. So in whatever previous disorders like corneal ulcers, be it viral, bacterial, acanthamoeba, in those cases, hypopyon was associated with red eye. It was associated with red eye. In endophthalmitis also, there was severe congestion, right? Okay. So that is why in Behçet's disease, why it is called as cold mobile hypopyon? Because eye is relatively white. Eye is not red. It is relatively white. That is why it is called as cold mobile hypopyon. Give me a thumbs up if it is clear. Why it is called as cold? Because eye is relatively white. It is not congested like in other ulcers or endophthalmitis where you were seeing hypopyon. Give me a thumbs up if it is clear. Cold mobile hypopyon, very important question. Cold mobile hypopyon seen in Behçet's disease associated with HLA B51 or B5. Okay, good. So after Behçet's disease, write down another cause. Write down cause. Next is juvenile idiopathic arthritis. Juvenile idiopathic arthritis. Short form is JIA. JIA. This is the most common disorder. This is the most common disorder associated with anterior uveitis. AU is anterior uveitis in pediatric patients. So if there is a girl, female, presenting to you with anterior uveitis, her age is around 9 years of age, then the most common cause, the number one differential which should come in your mind is juvenile idiopathic arthritis. Okay, juvenile idiopathic arthritis. Clear? Now, what are the signs which you see? What are the signs which you see in anterior uveitis in anterior chamber? So, can you see on the corneal endothelium, whitish deposition is seen? Big whitish depositions are present. The location of these white deposits is they are present on corneal endothelium, on the back of the cornea endothelium, right? So these depositions are called as Keratic Precipitates. They are called as Keratic Precipitates. Okay. So write down the signs of inflammation. Write down clinical features of anterior uveitis. Symptoms, write down first. Symptoms. Patient will be having sudden painful loss of vision. Because of inflammation, patient will have pain. So sudden painful loss of vision. So patient will be presenting with the complaint of severe pain. Now you will tell me, because the patient is having pain, which drug is coming to your mind to relieve the pain? To relieve the pain of the patient, which drug is coming to your mind? Which drug will you will prescribe? Cycloplegics. Correct. So because patient has steroids also, right? Good. So right, coming back to symptoms now. Patient will have sudden painful loss of vision with lacrimation will be there. Okay. Now coming to signs. So with anterior uveitis, patient will have circumcorneal congestion. Okay, so surrounding the cornea, all of the conjunctiva will be red in color. All of the conjunctiva is bright red in color. Important question. Circumcorneal congestion is seen. Next important sign with the picture which I have showed you, Kps. These are called as Keratic Precipitates. Keratic Precipitates. So these are present in which, what is the site? Endothelium. They are present on endothelium. Okay. Now suppose this is our cornea and this is your pupil and this is how the location and they look like Kps. They are most commonly seen in the inferior quadrant of the cornea. Inferior quadrant of the cornea in a triangle-like fashion. So write down, they are most commonly located. Keratic precipitates are most commonly located inferior part of the cornea in a triangle with apex pointing upwards. This triangle is called as Arl's triangle. Important question. This triangle is called as Arl's triangle. So Arl's triangle is made up of keratic precipitates and they are more commonly distributed in the inferior part of your cornea with apex pointing upwards. The triangle name is called as Arl's triangle. Okay. Now, one in Kps, write down what are the types of keratic precipitates. Types of keratic precipitates. The one which you saw in the image right now, that was mutton fat Kps. Remember, these mutton fat Kps are big in size. So that is why M for mutton and M for macrophages. So these are composed of macrophages. This also you have to remember, important question. Mutton fat Kps are made up of macrophages. Okay. Second type of Kps, write down. After mutton fat Kps, there are granular Kps also. Granular Kps are fine Kps, very fine, and they are composed of lymphocytes. They are composed. Granular Kps are composed of lymphocytes. So after keratic precipitates, next important sign, write down. All the signs you are seeing in aqueous humor, right? In anterior chamber. So you will see aqueous cells. Write down important point about aqueous cells. These are early and definitive signs. Of inflammation. Early and definitive signs of inflammation. Now, how they look like, how you see aqueous cells. Suppose the patient is having anterior uveitis and you make the patient sit on the slit lamp, right? So on very high magnification and full brightness, okay, we will examine the anterior chamber and very fine dots are seen as cells. They are called as aqueous cells. So if in anterior chamber, even if a single cell is present, that indicates that there is some amount of inflammation inside the eye. Okay. And another important sign after aqueous cells which we see is that is called as aqueous flare. Aqueous flare. So how you differentiate clinically? Aqueous cells are fine dots which you see in the anterior chamber floating in the aqueous humor, and aqueous flare looks like in a dark sunlight if you remove your curtain behind the sunlight, right? So can you have you appreciated fine particles are there when you remove the curtain against the bright sunlight? Fine particles you have seen. So those particles just resemble the same aqueous flare. Okay, so these are two signs which you examine on high magnification, and aqueous cells definitely they are the indicator of inflammation. Okay, so these important aqueous cells and flare you have to remember. Also remember, write down in aqueous cells, these aqueous cells are composed of, write down, they are composed of neutrophils. Mutton fat Kps were made up of macrophages. Granular Kps are made of lymphocytes. Aqueous cells are composed of neutrophils. Aqueous cells are composed of neutrophils. Another important question which is asked in aqueous flare, write down. These aqueous flare are seen due to leakage of protein. They are seen due to leakage of protein in anterior chamber. From where the protein is coming? From leaking iris capillaries. Remember, iris is a vascular structure. Iris is a part of uvea. Iris is a vascular structure. Because of vascularization, there is inflammation is there. So because of inflammation, iris will bleed. So iris will leak. And what is present in leakage? Proteins are present. So due to leakage of proteins, these aqueous flare are seen. Question which is asked in exam is that these aqueous flares are seen or they are visible due to which effect? So the name you have to remember, they are visible due to Tyndall effect. They are visible due to Tyndall effect. Tyndall effect. Whereas aqueous cells, they are composed of neutrophils. Clear? Aqueous flare is composed of proteins and they are seen because of Tyndall effect in anterior chamber. Next important sign, anterior uveitis. Because of inflammation, you will see hypopyon pus in the anterior chamber. We have already discussed that mobile hypopyon is seen in which disease? Behçet's disease. Behçet's disease. Another important sign which we can see, write down, that is called as iris nodules. These iris nodules, they are seen not in acute uveitis, they are seen in chronic cases of anterior uveitis. Chronic cases of anterior uveitis. So there are mainly two types of iris nodules which you need to know. One is called as Cope nodules. Cope nodules, and you have to remember the location of these nodules also. They are present at pupillary margin. They are present at pupillary margin. So how you will remember the location? Cope contains P and pupil is also having P. So Cope location is at pupillary margin. Next type of nodules, iris nodules, are called as Basaka nodules. Cope nodules and Basaka nodules. Now Basaka nodules location is, they are present along collarettes. They are present along the, can you tell me what are, we have discussed in anatomy, what were collarettes? Going back to the picture, I'll show you the iris nodules, how they look like. Thick part, yes, right. So these are the thickest part of the iris. Colorates are the thickest part of the iris, and these are the picture, right? So if the nodules, can you see these nodules are present at the pupillary margin? So P for cope. Cope contains P, so they are present at pupillary margin. Basaka nodules, can you see this elevated line is there? These are colorates, thickest part of the iris. So these nodules are present along the colorates. Which nodules? Basaka nodules. Basaka nodules are present along the colorates. Clear or any doubt? This much is clear? Give me a thumbs up if it is clear. Cope nodules, Basaka nodules clear. So location is also important. You need to remember the location of cope nodules as well as Basaka nodules also. Clear? Cope nodules are present at pupillary margin. Size is not important. They can be of any size. Okay. So cope nodules and Basaka nodules. Now next important sign, write down. Next important finding is posterior Cynicia. In uveitis, you will see posterior Cynicia. Now, Cynicia we have already discussed past yesterday, right? Yesterday in acute angle closure glaucoma, we have discussed past peripheral anterior Cynicia. So, anterior Cynicias were attachment between which two structures? Iris and the peripheral cornea. Now, can you tell me, we have already discussed posterior Cynicia. So, posterior Cynicia is attachment between which two structures? Iris and lens, right? Iris and lens. So why there is attachment? See, this is cornea, this is iris, anterior chamber. There is severe inflammation inside the anterior chamber. Lots of aqueous cells and flare are there. Behind the iris is your lens, right? So because of this severe inflammation, you will see formation of exudates. You will see clumps of the aqueous cells are formed and they form exudate, and these exudates are getting deposited behind the iris and in front of lens, and they causes this Cynicia, posterior Cynicia. Okay, so you will see posterior Cynicia also. Now, can you tell me, if there is posterior Cynicia, which problem will arise because of posterior Cynicia? Which problem can arise because of posterior Cynicia in anterior uveitis? Which problem can arise because of adhesion? Cataract, yes, cataract can also arise because why cataract can arise? Because there is adhesion of the iris and the anterior capsule of lens. So whenever the iris detaches, it will leave some opacity on the anterior capsule of lens that can cause cataract. Yes, there will be IOP increase and it can cause not secondary angle closure. Angle will not be closed, but yes, IOP will increase. IOP can increase in anterior uveitis because of posterior Cynicia. Aqueous humor is accumulating inside the posterior chamber, and there is no way of aqueous flow from PC to AC. Okay, so yes, intraocular pressure can increase. Good. Now write down posterior Cynicia. What we see in posterior Cynicia, write down. So you will see certain adhesions of the pupillary margin with the lens. Now, if you dilate this patient with posterior Cynicia, PS means posterior Cynicia, and you try to dilate this patient, what will be? You will see irregularly dilated pupil. You will see irregularly dilated pupil because there are some adhesions of the iris with the lens capsule, right? So this irregularly dilated pupil, write down, there is localized Cynicia is present. And if you the pupil, the shape of tuned pupil. So this type of pupil, irregularly dilated pupil, is called as festoon pupil. Irregularly dilated pupil is called as festoon pupil. If in any patient you see a festoon pupil, what does it mean? That the patient in the past may have got anterior uveitis attack. Okay, there must be some inflammation inside the eye. So posterior cynicia, if you try to dilate this patient, you will get irregularly dilated pupil, which is called as festoon pupil. Important question. Now write down next, what are the complications? What are the complications of anterior uveitis? What are the complications of anterior uveitis? You have already told me the most common complication is complicated cataract. Complicated cataract. The mnemonic for complicated cataract was? Mnemonic for complicated cataract we have discussed. Cataract appears because there is adhesion between iris and the lens because of synechiae, right? So because there is adhesion, when iris is removed, it comes back to its normal position. It will leave an opacity on the lens capsule that is called as cataract. Yes, Ramu Kaka. In Ramu Kaka, U was uveitis. U was uveitis, which was most common cause of complicated cataract. So most common complication is complicated cataract, right? Then second complication, write down. It is called as band-shaped keratopathy. Band-shaped keratopathy. What is band-shaped keratopathy? Write down. There is deposition of calcium ions in Bowman's layer of cornea. Now this is suppose your cornea. So you will see some band-shaped deposition of calcium ions in the which layer of cornea? Bowman's layer of cornea. Treatment is, write down, treatment is chelation is done with EDTA. So chelation is done with EDTA. Third complication of anterior uveitis, write down, it can lead to cystoid macular edema. Can lead to cystoid macular edema. Okay, so this is the most common cause of loss of vision due to posterior segment involvement. Due to posterior segment involvement. Okay. Now write down question which is asked. If they ask you what is the drug of choice for anterior uveitis, what will be the answer? What will be the answer? What is the drug of choice? EDTA, ethylene diamine tetraacetic acid. No need to remember the full name. Just remember chelation with EDTA. So drug of choice for AU, anterior uveitis, topical steroids, no. You have to give topical steroids, plus you have to give cycloplegics. Both are drug of choice. It can never be only steroids. It can never be only steroids. So you have to give both topical steroids as well as cycloplegics because patient has pain. Okay. So both steroids and cycloplegics are given. Clear? So next, write down. After anterior uveitis, we will discuss which is the second type of uveitis. After anterior comes your intermediate uveitis. Intermediate uveitis. Now tell me, what is the site of inflammation in intermediate uveitis? Site of inflammation. Where is the inflammation going on in intermediate? In anterior chamber or posterior segment? In vitreous? Aqueous humor or vitreous humor? Where is the inflammation seen? Vitreous humor, right? Vitreous humor. So you will see all the inflammation in vitreous humor, right? So now write down, also known as intermediate uveitis is also known as pars planitis. It is also known as pars planitis because there is inflammation of pars plana. So it is also known as pars planitis. It is associated with Lyme disease, also sarcoidosis. Remember, sarcoidosis was also seen in, it is also the cause of anterior uveitis. And here, it is also cause of intermediate uveitis. Similarly, tuberculosis also, and syphilis. So these are not important for your exam point of view. Causes they will not ask about intermediate uveitis. Just remember that other name is pars planitis of intermediate uveitis. Now what is important is write down signs. Signs which you see in intermediate uveitis. Write down. Ball opacities. Snowball opacities. What are snowballs? Write down. These are aggregation. These are aggregation or clumps of cells in vitreous humor. In vitreous humor. So signs are important, right? So you have to remember that snowballs are seen in intermediate uveitis. So what are snowballs? These are aggregation of cells. Cells will accumulate together and they will form a clump in the vitreous. So these are called as snowballs. Can you see in the retina? Can you appreciate these white dots? These dots? So these dots are called as snowballs. Now, if the inflammation is more severe, so what is the next stage after snowball? If these snowballs are associated with fibrovascular proliferation, can you see a fibrovascular membrane is present here? So this fibrovascular proliferation is called as snow banking. Snow banking. So in intermediate uveitis, what things you have to remember? It is also called as pars planitis. Two important signs you have to remember: snowballs and snow banking. Okay, clear? Right. So write down snowballs and snowballs, and second is snow banking. Snow banking. So write down, this is associated with fibrovascular plaques. Fibrovascular plaques. So snowball and snow banking are very, very important. Coming back to the complication of intermediate uveitis. So it can lead to cystoid macular edema. Why macula is involved? Because signs are seen in retina, right? So that is why there can be inflammation in the edema. It can be there in the macula. So this can lead to cystoid macular edema. Okay. So this is the most common cause of loss of vision in intermediate uveitis. It is a very severe form of uveitis as compared to anterior uveitis, right? So as I've told you, anterior uveitis is more common entity. Anterior uveitis is most common one. But intermediate uveitis is more severe as compared to anterior uveitis. Why cystoid macular edema is seen? Why? You tell me why. What is the location of macula? Location of macula is present in the retina. Now, if the signs of inflammation are seen in retina, there will be signs of edema seen in macula. So that edema is called as cystoid macular edema. And macula is responsible for central vision and maximum vision because fovea centralis is present in the center of the macula, right? So intermediate uveitis, obviously, yeah, foveal reflex will be absent. Fovea is also getting involved in the edema. So patient will have severe loss of vision in intermediate uveitis as compared to anterior uveitis. So this intermediate uveitis is severe infection or inflammation as compared to anterior uveitis. So that is why in anterior uveitis we were giving topical steroids. In intermediate uveitis, topical steroids alone will not help. So you have to give injections. Write down. Treatment is periocular steroids. You have to give periocular steroids injections. Okay. Periocular steroids are given. Now, after intermediate uveitis comes your posterior uveitis. Posterior uveitis. Posterior uveitis. Write down important causes of posterior uveitis. The most common cause of posterior uveitis is very, very important. It is toxoplasmosis. Toxoplasmosis. Two appearances are seen in toxoplasmosis. If you see the retina of this patient with toxoplasmosis, you will see two findings will be there in the retina. What is the name of these findings? Headlight in fog appearance. Headlight in fog appearance. And second finding you will see punched out scar. Punched out scar. These two findings are very, very important in toxoplasmosis and posterior uveitis. So two findings, the name you have to remember. Yes, after steroid injections, if we start the patient on time, patient usually get a good prognosis. Vision can be regained. If edema decreases after steroids, vision will also improve. So in toxoplasmosis, two findings, headlight in fog appearance and punched out scar. How this appearance looks like. Can you see a scar is present at the macula? So this is a typical finding, punched out scar seen in toxoplasmosis. Okay, typical finding of posterior uveitis. Clear? And can you see these adhesions? The pupil is not round. There are certain adhesions of the iris at the anterior capsule of the lens. And if you dilate this patient, it will give you irregularly dilated pupil that is called as festoon pupil. That is called as festoon pupil. There is no image of arch triangle. I have shown you the diagram. It will look like this. You will see certain depositions of Kps in the triangle-like fashion. This is the picture of Kps. This is a picture of mutton fat KPs. This is how they look. In this picture, they are distributed in the whole of the cornea, but it is not essential that KPs are distributed in a triangular-like fashion only. It is not a rule, but usually they are seen in triangle-like fashion in the inferior of the cornea, inferior part of the cornea, right? So these are how the mutton fat KPs look like. And this is how the headlight in fog appearance look like. Why this is headlight in fog it is called? Because it gets foggy because of severe inflammation in the vitreous humor, which leads to severe vitritis, right? So this is how the picture of headlight in fog appearance looks like. So two findings in toxoplasmosis: punched out scar at the macula and this headlight in fog appearance you have to remember. Again, this is also a severe inflammation, severe infection as compared to anterior uveitis. So only topical steroids will not work. So drug of choice, write down. Drug of choice for posterior uveitis, you have to give intravitreal or systemic steroids. Intravitreal or systemic steroids are given in posterior uveitis. This is all about your posterior uveitis. Next comes your pan uveitis. Pan uveitis was inflammation of iris, ciliary body, and choroid. All of them are getting involved, right? So in pan uveitis, we will discuss one entity or one pathology. The name is sympathetic ophthalmitis. Itis is there, that means there is inflammation, right? So this is an autoimmune disease, write down. This is a bilateral. Both eyes are getting involved. It is bilateral autoimmune T-cell mediated pan uveitis. Okay, write down the most common cause of sympathetic ophthalmitis. It is accidental penetrating trauma to ciliary body. CB is ciliary body. That is why the ciliary body is also known as dangerous area of eye. So that is why it is called as dangerous area of eye. If diffuse KPs are present, we don't call that as arch triangle, right? Yes. If diffuse presentation of KPs is there in all over the cornea, we don't call it as arch triangle. Arch triangle is present in the inferior cornea only, with apex pointed upwards. Okay. Now, what is concept behind sympathetic ophthalmitis? Try to understand. It is pan uveitis. Whole of the layers are getting involved. Means this is a very severe inflammation. First thing, most severe one. Second thing, the most common cause is penetrating trauma. The trauma with this pen, if it punctures my right eye, only this can give me, penetrating trauma can give me sympathetic ophthalmitis. No blunt trauma. If there is injury with blunt object or fist injury is there, it will not give me sympathetic ophthalmitis. Okay? Because it won't damage ciliary body. So this penetrating trauma can touch your ciliary body. It will damage your ciliary body. So that is why the most common cause is penetrating trauma to the ciliary body. Okay. Now what will happen? Suppose there is penetrating trauma. Now what will happen within 14 days, within 2 weeks? What will happen? the reaction of this eye, inflammation of this eye through the bloodstream can transmit to my other eye. Okay, so in traumatized eye is this one, right eye. The inflammation is getting transferred to my left eye. Okay, understood? So which eye, the sympathetic ophthalmitis is developing in which eye? My right eye or my left eye? Tell me. Sympathetic ophthalmitis is developing in my right eye or my left eye? This is my traumatic eye. Reaction after 14 days starts through the bloodstream and it is transmitted to my left eye, right? So sympathetic ophthalmitis develops in my left eye. Okay, understood? Why? Because traumatic eye was this eye, so you should have sympathy for my left eye. Because there was no trauma in my left eye, still inflammation is getting transmitted to my left eye, so you should have sympathies for my left eye. So non-traumatized eye is your left eye. Clear? Non-traumatized eye is getting your sympathetic ophthalmitis. Clear? So write down CB. It is also known as dangerous area of eye. Write down the pathogenesis of sympathetic ophthalmitis. It develops due to trauma to one eye. This traumatized eye is also called as exciting eye because it is exciting the reaction. Now what will happen within 2 weeks to 3 months? Within 2 weeks to 3 months, uveitis is seen in uninjured eye. In uninjured eye, also called as fellow eye, the other eye. This eye is called as sympathizing eye because you should have sympathy for this eye. Okay. So this is the basic concept. Talking about clinical features, if they ask you which is the first symptom of sympathetic ophthalmitis, then answer is difficulty in near vision. Now you will tell me what is the logic behind this thing? Why there is difficulty in near vision in sympathetic ophthalmitis? Which structure is getting damaged with the penetrating trauma? Which structure is getting damaged with the penetrating trauma? Which structure is getting damaged? Ciliary body. And what was the function of ciliary body? Ciliary body is responsible for aqueous humor production. And what is the other function of ciliary body? Accommodation, right? And accommodation is responsible for near vision or far vision? Near vision, right? So that is why the patient will have difficulty in near vision in sympathetic ophthalmitis. Clear? Now next, write down. Difficulty in near vision will be there and patient will also have some photophobia. If they ask you first sign, then you will see Keratic Precipitates, Kps will be there, and you will see retrolental flare. Retro means behind, lental means lens. Flare can be seen behind the lens. Okay. So because this is a very severe infection, what is the treatment? Visual prognosis is very poor in these patients. Now, if scenario number 1, write down, if there is no visual potential, in traumatic eye, if there is no visual potential of traumatic eye, means eye is blind. Then you do enucleation. We do enucleation of the traumatic eye. Don't remove the other eye. Other eye is okay, right? It will be having some vision. So you have to remove the enucleation is done of the traumatic eye. Why the traumatic eye? To prevent Uveitis within of trauma. Within 2 weeks of trauma. Okay. Now try to understand. Suppose my right eye has developed penetrating trauma. Okay. Now, if I present to the doctor and doctor has seen that my ciliary body has damage with this pen. Okay. SO means sympathetic ophthalmitis. My ciliary body has got damage and there are high chances that after 14 days, the reaction will pass on to the other eye. And if I am blind with this eye, it has no visual potential. So in order to protect my other eye, what will I do? What will I do? I will remove this eye. And this removal is called as enucleation. What we do is enucleation. Okay. So I will enucleate the eye in order to prevent sympathetic ophthalmitis to develop in other eye. So is it a treatment? Can you tell me sympathetic ophthalmitis this enucleation is a treatment or prophylaxis? It is just a prophylaxis because I am preventing the sympathetic ophthalmitis to develop in other eye. Okay. What we do after enucleation? Leave it empty. No, we implant some, we give prostheses. Okay. Prosthetic implants are given to the patient for cosmetic reasons. So we have to do enucleation of traumatic eye, right? Now, second option, second scenario, if already sympathetic ophthalmitis has established in other eye also, and patient has some vision, patient is not blind, then what will we do? We will not remove the eye if patient is having some vision. Then what will we do? We will try systemic steroids, periocular steroids, topical steroids, whatever is the possibility, we will try. But prognosis is poor. Prognosis is poor. So if patient has some vision, if some vision is also there, then we cannot remove the eyeball. Okay. So we will start with oral steroids, systemic, periocular injections, and topical steroids. All the forms will be tried. Clear? Now write down. So we have studied these two operations of removal of eyeball. One was evisceration. So can you tell me in which pathology we were doing evisceration? Yes, it will affect optic nerve. So can you tell me in which pathology we were doing evisceration before? Endophthalmitis, right? So write down. So there has to be some difference between evisceration and enucleation, right? So for your query, I want to tell you this evisceration operation is the first operation which we give to first year postgraduate in ophthalmology because it is a destructive process. You have to remove all the contents of the eyeball, right? So that is why this is the first surgery we give to your first year PG resident. Okay. Next heading, write down removal of eyeball. Removal of eyeballs. Removal of eyeball. First is enucleation. Enucleation. What we do is write down removal of globe is done. Means, what do you mean by globe? Whole eyeball along with optic nerve is removed. Okay, so that infection may not transmit to brain via optic nerve. That is why we have to remove optic nerve also. What are the indications of enucleation? First one is trauma, which we have recently studied, sympathetic ophthalmitis. And second indication is retinoblastoma. So because of in retinoblastoma, tumor cells can transmit from the optic nerve to the brain. So it is very essential to remove optic nerve. Okay, so that is why we go for enucleation in trauma and retinoblastoma. Second is evisceration. Evisceration. Evisceration, what we do, there is a removal of, it is removal of all contents of eyeball except sclera. Except sclera. EOM is extraocular muscles and optic nerve. So these three structures are left behind. Now, what are the indications of evisceration? One we have already discussed in endophthalmitis. And third is panophthalmitis. Blind eye in endophthalmitis and panophthalmitis. Removal of optic nerve may bring risk to the patient. No, we are preventing the patient from the risk of retinoblastoma. If we don't remove optic nerve, see, when we will discuss retinoblastoma, then there's an important question. The mode of transmission of retinoblastoma is through optic nerve. So if retinoblastoma metastatic cells are transferring through optic nerve, so in order to prevent that transfer of metastatic cells, you have to remove optic nerve. If you don't remove optic nerve, metastasis can go from the eye to the brain and death will be there. Okay, so you have to go for enucleation in retinoblastoma. EOM is extraocular muscles. So in evisceration, sclera is kept as it is, extraocular muscles and optic nerve. Okay. See, enucleation is done in sympathetic ophthalmitis. Yeah. Please correct the PDF because you said enucleation in system ophthalmitis. Enucleation is done in sympathetic ophthalmitis. Evisceration is done in endophthalmitis. Okay. So I have written right in sympathetic ophthalmitis. Enucleation is done. Don't get confused. In enucleation, we are doing it in trauma and retinoblastoma. Clear? So this is all about uvea. We'll take a 15 minutes break. At 3 o'clock. We'll start again with a new topic. Okay.